You're at the cutting edge of cardiovascular sciences. I'm John Cooke, Professor and Chair of the Department of Cardiovascular Sciences here at Houston Methodist Hospital. And we have a very special guest for us today. It's going to be talking about genetics and cardiovascular health. I'm joined in the studio by Dr. Lai, who's a faculty member in our Department of Cardiovascular Sciences, and she's going to introduce our guest.
So today it's my pleasure to introduce Dr. Joshua Knowles, Assistant Professor of Medicine in the Division of Cardiovascular Medicine at Stanford University. Dr. Knowles is a leading physician scientist specializing in the genetics in cardiovascular disease, lipid disorder, and precision medicine. He completed his MD PhD at the University of North Carolina at Chapel Hill under the mentorship of Nobel laureate Oliver Smithis, followed by internal medicine residency and the cardiovascular medicine fellowship at Stanford, where he trained under Dr. Thomas Quintermus. He joined the Stanford faculty in 2014 and is now the director of the lipid clinic within the Stanford Center for Inherited Cardiovascular Disease, where he actively sees patients while also leading groundbreaking translational research. The fundamental theme of Dr. Knowles' work is the application of genetics to improve human health, spanning from discovery research to clinical translation and public health initiatives. His research focuses on the genetic mechanisms of cardiometabolic risk factors such as insulin resistance and hyperlipidemia, which are supported by prestigious agencies including NIH, HA, ADA, and the Doris Duke Charitable Foundation, etc. So in addition to his research and clinical contributions, Dr. Knowles is passionate about training the next generation physician scientists. As a director of Cardiovascular Medicine Fellowship Program, he has mentored numerous trainees with over 80% receiving Mentor Training Award during his tenure. Please join me in welcoming Dr. Joshua Knowles and looking forward to your talk.
Josh, it's a pleasure to have you on the show. Thank you for joining us.
No, it's great to be with you virtually, with old and new friends. And I just remember fondly your time here, John, before we lost you. And I'm glad you invited me.
Well, we're looking forward to hearing your talk, and thanks for those kind words. Before we start, Josh, I just want folks that are listening in to know that they can ask you questions, and Dr. Knowles has kindly offered to take questions before, during, or after his talk. So to ask questions, if you're on your terminal, go to pollev.com. That's POLLEV.com, and enter DeBakey, DEBAKEY, and respond to that activity. Or you can join us by text and dial 37607 and text DeBakey, DEBAKEY. Text us your questions. That'll show up on the monitor here, and we can ask Dr. Knowles your questions. Josh, you are a classic physician scientist doing teaching, clinical care, and research. How do you manage to do all that?
Well, I think first, thank you for that. I think the most important thing is you have to believe in the mission and keep your eyes focused on the mission. And we don't believe in this false dichotomy that you can't be a great doctor and also a great researcher at the same time. And I think obviously, as you well know, the most important thing is to surround yourself with amazing trainees and people that you work with that can help extend the kind of work that you do.
Yeah, that's sage advice. And it also helps to have a very focused research program, which you do. In addition, which we're going to hear about, in addition, you have a training program at Stanford. Tell us a little bit about your training program.
Yeah, thank you so much. You know, we have, like many great cardiology training programs, we have 7 fellows per year, and we usually get about 700 applications like many other places. And our program is some things that we're really proud of, which is all of our trainees get a year of research after doing 2 rigorous clinical years. And we try to prepare them for careers as leaders in future. And we have things like grant support mechanisms for our trainees. So we teach fellows not only how to read echoes and do angiograms, but we also teach them how to write grants and successfully apply for funding so that they can launch their independent careers at the end of it. And we're very proud of the success we've had in doing that and helping our trainees get great jobs within academics and out of academics.
That's great. And I understand you have also a focused clinical effort in hyperlipidemia. You're probably doing some training there at the bedside for those trainees. Tell us a little bit about your clinical practice.
Yeah, so I have a lipid clinic. I work under the auspices of the Stanford Center for Inherited Cardiovascular Disease, which you can see our logo, and I'm wearing the vest with our little logo here. And we have an umbrella clinic where we believe that we can deliver cutting-edge treatment and diagnosis and therapy to patients that have been born with a genetic predisposition to heart disease. So I run the lipid clinic. I see patients with familial hypercholesterolemia or high triglycerides, statin intolerance, et cetera, about half a day a week. But my colleagues also see patients that have hypertrophic cardiomyopathy and Marfan syndrome and inherited arrhythmias, arrhythmogenic cardiomyopathies, et cetera. We have full-time genetic counselors embedded in the clinic with us and offer genetic testing when applicable. And we find that this is an incredible way to marry our research and clinical interests because it allows us to recruit patients for clinical trials that they might be interested in or do natural history studies, et cetera. So marrying the clinical and the research interest, I think, is very important.
Yeah, what a spectacular research, education, and clinical environment. Well, let's hear more about your research, Josh. Why don't you go ahead and start? Your slide is up on the screen.
Thank you so much. And I promise to keep it short and sweet so that we have time for questions. You know, talking about genetics of cardiovascular disease could encompass many weeks. And I think I'm going to tell you a few vignettes, but I just wanted to say these are things that I'm not going to talk about during my talk, but if there are questions about them later, we're happy to address them. I'm not going to talk about using whole genome sequencing for patient care. You know, you guys are in Houston and are well aware of the incredible utility that has for some patients. I'm not going to talk about variant classification, which is really important when we give information to patients about their own genetic testing results. Are their variants pathogenic or not? It's really important, but it's a bit dry. I'm not going to talk about medical mysteries. And I'm also not going to bring Cole to Newcastle and talk about genetic disease modeling with human iPSCs. I think Dr. Cooke and his colleagues have probably educated everybody about that in the past. I am going to talk about some other aspects of gene discovery to clinical application. And I adapted this slide from a review many years ago by Betsy Nabel and Chris O'Donnell, where they talked about the genetic revolution that was coming in medicine. And they mentioned GWAS, gene discovery, and I'm going to talk a little bit about that. Hypothesis-driven research, smarter drug discovery was not something they mentioned. But then I'm going to touch on two things that they didn't necessarily forecast, and which one of them was, how can we improve public health aspects of genetic care, and how can we do personalized therapy, including gene editing, which was not yet on the radar. So I'm going to tell you 3 vignettes, the first 3. I'm going to talk about gene discovery and mechanisms, about insulin sensitivity, how we use modern genetic techniques to do smarter drug discovery. And then I'm going to very briefly touch on the intersection of machine learning and genetics for the last vignette. I'm not going to talk about the routine use of genetic testing or polygenic risk scores or gene therapy so much as therapy, because I think if there are burning questions about that, happy to talk about that in the discussion, but we have a limited time for this talk. I like to show this slide for gene discovery to the trainees, and I say, well, who was on the Darwin? And sometimes people can tell me who was on the Beagle, and it's Charles Darwin, obviously. And in 5 years, which is a typical NIH grant, he accomplished a lot and really set the stage for genetic medicine, several hundred years later. And the disease mechanism and disease that I really focus on in the lab, in my basic science lab, is insulin resistance and diabetes. And we have a global pandemic of diabetes by 2045. We estimate there'll be 700 million diabetics. Obviously, we're going to have an increase in North America, but there's going to be increases across the entire world. And somebody that John Cooke knows well, because they were neighbors in their offices many years ago, was Jerry Reaven. Jerry Reaven was a mentor of mine, and he really established the idea that insulin resistance was critical for the development of diabetes and also cardiovascular risk. And one of the things that he described very early on was that insulin sensitivity, insulin resistance, is a quantitative trait like any other quantitative trait, and it differs by 600% between the most insulin sensitive and most insulin resistant individuals. Most people with insulin resistance do not get diabetes. Most people with insulin resistance have a sufficient insulin response. They get compensatory hyperinsulinemia that prevents diabetes, but they still have overt cardiovascular disease risk factors from that. And those that pancreas cannot keep up with the demand, go on to develop diabetes. And insulin resistance is a key component, necessary but not sufficient for diabetes, but also a major risk factor for heart disease, for fatty liver, for certain forms of cancer. And so we're really interested in understanding the genetic basis of that.
Josh, before you leave that
diabetes in general. And I think one of the things that has come from the genome-wide association revolution is that we now understand that diabetes and insulin resistance are hand in hand, but that susceptibility to diabetes itself is not monolithic. And there are many ways to get to type 2 diabetes. Some of those pathways and genes are involved in decreased insulin secretion, decreased insulin production, and others are associated, other genes seem to regulate tissue level insulin resistance, fatty liver, fat deposition, lipodystrophy, and obesity. So we cannot think of type 2 diabetes as monolithic. My lab has been mostly focused on tissue level insulin resistance and trying to tease out the genetic underpinnings of that.
Josh, I'm sorry.
Yes,
if we could go back to this previous slide, I'd just like to dwell on that for just a moment, that broad range of insulin sensitivity that you're showing in that slide that Jerry Reaven documented. It's quite amazing that there's such a range. And as you pointed out, I mean, it's an order of magnitude or more, the difference between the lowest and the high. Is there also resistance and the risk of cardiovascular?
That's a very nice thing to point out, that the more insulin resistant you are, the more risk you are, not only of diabetes, but also of cardiovascular disease, fatty liver, et cetera. And it also seems like if you get diabetic, if you become a type 2 diabetic, it also matters what is the genetic underpinnings. Those that develop diabetes and have a strong genetic predisposition to insulin resistance seem to have a higher risk for cardiovascular disease than those that get diabetes, maybe because their beta cells are not working as well. So that's something that we're just trying to untangle and understand, but there's a critical links between those things.
And could you remind us how Dr. Reven demonstrated that that spectrum of insulin resistance in patients, in people?
Yes, yes. This is called the steady state plasma glucose, and this is an assay that they helped develop, and it's an invasive measure. It takes many hours. You take people into a GCRC or equivalent, and you start IVs in their arms, and in one arm you infuse octreotides to suppress endogenous insulin secretion, and in the other arm you infuse glucose and insulin. And those that are insulin resistant, their steady state plasma glucose levels rise, and those that are insulin sensitive, their steady state plasma glucose levels do not rise as much. And so this is a quantitative gold standard assessment of insulin resistance, and it's very difficult to perform. Less than several thousand people have had these measures performed probably in the world history. So there are other surrogate measures of insulin resistance, but this is one of the gold standard measures, the other being the euglycemic clamp, which is somewhat similar.
So what do we use in the clinic now, Josh, to assess insulin resistance in patients?
So that has to be done in a kind of using surrogate measures. And so there are many surrogate measures that are correlated with insulin sensitivity, but the correlations with all these surrogate measures are somewhat modest. Things like being obese is associated with insulin resistance. High triglycerides, low HDL is associated with insulin resistance. VLDL levels that are high triglycerides. So when we see a patient in front of us, we kind of have to make that judgment. We can also look at things like response to oral glucose loads and those kind of things. I do have a slide about some of those surrogate measures later, but it's an overall gestalt in many ways. Unfortunately, we don't have a gold standard measure that we can use in the clinic on a routine basis.
What about a fasting insulin and fasting glucose? Is that useful?
They are useful, but again, their correlation with, so fasting glucose levels are a composite of both your insulin sensitivity and your insulin secretion. So their correlation with insulin sensitivity with gold standard measures is only modest. And the same is true for fasting insulin, which also reflects what is your beta cell function. So they're useful, but they don't tell the whole story. And one of the difficult things with fasting insulin is that laboratory standards around the world are not the same. So if you're measuring insulin in one lab, value might not be translatable to another value. We don't have like the equivalent of an INR for fasting insulin levels. So that's why it's not as routinely used. If you use it in the same lab over and over again, it can be useful.
Yeah. Thank you.
No problem. Let's see. So we have spent many years now, and I've just highlighted a few of these papers that have come out of our lab, trying to discover some of the genetic variants, genes that are associated with insulin resistance. I'm not going to talk about these papers. Many of them are 5 or 6 years old. But what I'm going to say is that we now understand, and this is another way of looking at this, that susceptibility to diabetes comes in a palette. Everybody is born with a palette of susceptibility. And ultimately, that none of these are deterministic, but they do increase your risk. Some people are more predisposed to diabetes because they're born with risk factors that make them more likely to become obese or have excess adiposity. Some are predisposed to diabetes because they actually cannot deposit fat in places where it should be deposited in a lipodystrophy-like manner, and that inability to store excess energy in fat makes it deposit in other tissues, which leads to insulin resistance. Some get diabetes because their pancreas does not make enough insulin, and then there's others that we are trying to understand how they work through insulin and insulin resistance like mechanisms. So one of the conundrums that we've discovered through the genome-wide association era is that we often find areas of the genome that are associated with a phenotype, but we don't necessarily know what gene is active. And I'm going to give you two examples. This is one example, and I got lucky when we did our first genome-wide association study, and we found a gene that was associated with insulin resistance gold standard measures. And the variant that we identified was actually a coding variant in that gene that was leading to that association. That's quite unusual. Usually when we do these genome-wide association studies, we find an area, a peak of association, a region of the genome that's associated with a phenotype, but there are many, many genes within that region, and it's difficult to determine with certainty what is the gene that is acting to cause the phenotype. And so a lot of what we have been doing over the years and what many people have been doing is to try to find out what are the causal genes, what are the causal mechanisms for various disease states, in this case, insulin resistance. And I can't go through all of the ways that that's done, but there's in vivo models that are used, mice models, there's flies, there's zebrafish. There are screens that we can do in vitro, and I'll show an example of this later. There's induced pluripotent stem cell models, there's human perturbations. But for the first part of what I'm going to talk about is a technique called fine mapping using an expression quantitative trait loci, SNPs or polymorphisms in the genome that are not only associated with a phenotype, but also associated with gene expression to kind of narrow down our search space. And I'm going to talk about how powerful that has been for several examples. And the idea behind this is quite simple. We have a genome-wide association study where we have a variant that's associated with a phenotype. And then within that area of the genome, we also look to see if those variants that are associated with the phenotype are also associated with expression of genes in that region. And so we must have both genome data from DNA, and then we also have to marry that to expression data, that is RNA data from tissues. And these are two examples. This is from a review article we wrote a few years ago in JACC. Here's two examples. In the top example, we have a variant that's associated with a phenotype, and we have QTL variants, but they're not overlapping. And in the bottom example, we have a variant that's associated both with the phenotype as well as being associated with a gene within that region of the genome. And there we're more confident that the association is due to that specific gene. And so that when you're a basic scientist, you don't want to tell somebody in your lab to start working on a gene unless you're convinced that that gene is going to be important. And these EQTL data, expression quantitative trait loci data, can be gathered for different tissues and even for different cells. And so then we can become confident that if a variant is associated with a phenotype, it's not only associated with a specific gene, but which tissue that gene is acting in. In this case, this example is a SNP that was acting in blood. And so we did this kind of study, and we took, as John alluded to, many different phenotypes that are broadly associated with insulin resistance. Gold standard measures of insulin resistance, but also things like fasting glucose, fasting insulin, presence or absence of diabetes, lipid levels that are associated with insulin resistance. And we also looked at expression data from tissues that are important for insulin resistance. And we tried to integrate these data to try to narrow down our search space. And what we found, and this paper came out a few years ago, is that if you start with genetic loci where there's a lot of potential co-localized, potential genes that are active, in many cases we can narrow from potentially 20 candidate genes that you start with. In many cases, you can find only one or two genes that might be important. And that's summarized in this slide. So we started with 817 genome-wide association loci associated with phenotypes related to insulin resistance. And in about 207 of those, we were able to fairly confidently narrow our search space to a specific gene of interest. And not only were we able to figure out what those genes were, but we were able to figure out which tissues they might be active in, and especially, fat tissue, liver, muscle, etc. Some of them have activity in multiple tissues. And then we were also able to marry this to other data sets that we had to figure out if these genes of interest, are they changed by things like glucose or insulin stimulation in vitro. So here, these are perturbation experiments. And so if you're trying to study something related to insulin sensitivity, the change in gene expression level when you perturb it with relevant perturbations might be quite interesting. The other thing that we were able to do in this paper, which I find important for ultimately therapeutic purposes, is to try to figure out if I was to knock out or knock down that particular gene and protein of interest, is that likely to improve or worsen the glycemic effect? And so obviously it's easier to inhibit something. And so if you look at this list, these are all co-localized genes. We know which tissue they're active in. We know which phenotype they're active in. And if we knock them down, are they going to make you more insulin sensitive or more insulin resistant? And so these are the kind of things that we're doing to try to find new drug targets for insulin sensitivity. We have expanded this effort to look at things like fatty liver. Fatty liver is a very understudied, it's an area that needs therapies to treat. It's a big cause of liver dysfunction, liver transplant now. And I was very proud of Peter Gustafson, who pushed this work through even during COVID. This paper recently came out in Hepatology, and it's just another example of how we started with co-localization and made our way to potentially drug targets. And in this case, instead of looking at insulin sensitivity per se, we looked at the phenotype of fatty liver, MASLD, and looked at various phenotypes associated with that, ALT levels, liver enzymes, etc. He even devised a new score for fatty liver. Then Peter also created a model system to study fatty liver, which is HepaRG cells that were either not or laden with lipids or laden with lipids, and you can see the lipid droplets accumulating. And this co-localization pointed us to many genes that might be of potential interest. And then what we did is we knocked these genes out in cells and then sequenced, and then not only saw the phenotype, but also the effect on transcriptional levels. And this is an example of that. So fatty liver, liver HepaRG cells that were lipid laden. Then we sorted them by the amount of lipids that were present, and then we were able to knock genes in or knock genes out using a CRISPR technology, and see the effect on the lipid droplet deposition in these cells. And what we found was that there are several genes that had been co-localized that, when they were knocked out, seemed to reduce lipid levels. And one of these is VKORC1, which is involved in vitamin K clotting factor and production. And what we can see is if we knock this gene down, this VKORC1, it decreased lipid deposition, and Plin2 is a marker for fat in these cells, in its liver cells, and it reduced the amount of fat that was in these liver cells. So it was a novel way of coupling co-localization to potential therapeutic development. Okay, that's the first vignette. I'm going to move on now to the second vignette. Smarter drug discovery. Any questions, John? Or should I move on to the next vignette?
No, that was good. Keep moving on.
Okay, so smarter drug discovery, less costly mistakes, and less adverse side effects. And I also show this slide to trainees and ask them who these folks are. And this is Watson and Crick with their original model of DNA. And all major pharmaceutical companies now have genetics wings to try to help them avoid making costly mistakes or help them prioritize genes or drug targets. And one of the ways that we are doing this is through this approach called Mendelian randomization. And Mendelian randomization is, like I like to say, like nature's clinical trial. Instead of randomizing people to a drug or not drug, all of us have been randomized to receive certain alleles at gametogenesis. Before we're born, we are either randomized to receive one allele or the other, from one of our parents or the other. And we can use these approaches to try to figure out what is causal and what is not causal, and that's really quite important. And the example that I like to give is for coronary heart disease. These are all risk factors for coronary heart disease, but we don't know which one of them are causal or not causal. Reading a newspaper is associated with coronary heart disease, but that's not causal necessarily. eating ice cream is associated with shark attacks, but that's not necessarily causal. So we use Mendelian randomization to try to figure this out. And that basic idea is that if a biomarker, like those present here, is causally associated with the phenotype, then the genetic underpinnings of that biomarker should also be causally associated with that phenotype. And in this case, after this, using this Mendelian randomization framework, we've been able to show, not me per se, but the scientific community has been able to show that those that are in blue here likely have a causal relationship with coronary heart disease. Those in the red are likely associated but not causal for coronary heart disease. So if you're a pharmaceutical company, you're all likely to want to prioritize targeting causal biomarkers. And the number of Mendelian randomization papers has just been going through the roof because this has proven to be so important, and we published a few papers in this area. And one of the things that came out of these studies that was quite interesting to me, because I'm interested in insulin resistance and lipids, is that after the statin trial, major statin trials came out many years later, there started to be a signal that those that took statin seemed to have a slightly increased risk for diabetes. And this was from randomized clinical trial data. And then it turns out that if we use the genetic evidence, it turns out that those that are predisposed to higher cholesterol levels are also have a protection against the development of diabetes. And those that are predisposed to have lower cholesterol levels have a little bit higher risk for diabetes. So there's both genetic and clinical trial evidence to support this idea that there's a link between lipids and diabetes that have not yet been fully understood. And there are many potential reasons for that. And so Jerry Reven actually and I collaborated with Hayo Coley and several others in analyzing some clinical trial data from the statin clinical trials. And what we showed in that paper is that in those with normal fasting glucose, these are triglyceride levels, high triglycerides or low triglycerides. If you had normal fasting glucose and normal triglycerides and you received a statin, the risk for developing incident diabetes is very, very low and really not different than those that did not get a statin. However, if you had prediabetes and a high triglyceride and you got a statin, your risk for diabetes is significantly higher than if you got placebo. So statins seem to increase the risk for diabetes, and that increased risk seems to be confined to those that are insulin resistant, overweight, and pre-diabetic. But the question that remained was, is this because statin medications are decreasing beta cell function, or are they increasing insulin resistance? And so in work that was funded by the Doris Duke Foundation, we did a little clinical trial to try to figure this out. And this is that gold standard measure of insulin sensitivity that I talked about before, the SSPG. And this is a measure of insulin production called the graded glucose infusion. And the trial design was quite simple. We measured insulin sensitivity and insulin production in individuals before and after 10 weeks of high-dose statin. And what we discovered is that those that insulin and statin treatment led to an increase in insulin resistance that was not accompanied by a decrease in beta cell function. In fact, beta cell insulin, the body seemed to make more insulin resistant. There seemed to be compensatory hyperinsulinemia. Now, we haven't figured out how statins cause an increase in insulin resistance, and I've written several grants to try to get funding for that and have not yet been successful, but that is a critical link that we're trying to uncover, and we certainly would not have gone down that road if we hadn't had genetic information. So that's the second vignette, and then I have one more vignette that I was going to briefly talk about, and I think this is where the world is going. So I wanted to really talk about the intersection of genetics and machine learning and quote, quote, artificial intelligence, which is kind of a loaded term, but I think it's really important. And this all started when I became involved as a volunteer with the Family Heart Foundation, which is a patient-led research and advocacy organization that was founded by Catherine Wildman, who's here. She's a native Texan, and this is 1 year before her myocardial infarction. She had quite severe coronary disease in her late 30s. And her experience with being undiagnosed and untreated led her to found this foundation. And our mission with the foundation is to try to prevent these kind of adverse outcomes. And so we said, well, an obvious step when I became involved with the foundation was say, okay, well, let's try to identify all the people in the health records that have familial hypercholesterolemia. Surely I could go to Houston Methodist, or I could go to Stanford, I could go to, MGH, and I could ask, to get a list of all the patients that had an ICD-10 code for familial hypercholesterolemia. And we were shocked to learn that there was no ICD-10 code for that, and so we actually created an ICD-10 code for familial hypercholesterolemia that was instituted a few years ago. But that had not yet been applicable. So that was one approach. But we didn't want to wait for the ICD-10 codes to be propagated in the medical records. And so we said, is there a way that we can identify previously undiagnosed FH patients before they have adverse outcomes? And the rationale for this program and this initiative, which we call the Find FH project, was that familial hypercholesterolemia is common. It affects about 1 in 250 people worldwide. Familial hypercholesterol is deadly. It affects families, and it's very preventable. If we identify individuals at a relatively early age and start them on statin-based regimens, we can massively reduce their morbidity and mortality. We know it is underdiagnosed. At the time we started this project, less than 1% had been diagnosed. We know that it is misunderstood and undertreated. And so we decided to see if we could take advantage of this newly emerging technology, machine learning and artificial intelligence in medicine, to identify previously undiagnosed patients. And the way this works is relatively simple, and it comes back to something that John let me point out earlier, which is that the marriage of the clinical and research. We were able to take advantage of the fact that we have a large clinic of familial hypercholesterolemia patients that we have identified and have done genetic testing on. And you need a large database of patients, because the way that these programs work is that you take true positive examples of familial hypercholesterolemia that we had identified or that had been identified at other institutions like Penn, and you basically teach a computer what a familial hypercholesterolemia patient looks like across the entirety of the medical record. And then you ask it to find other examples of patients that have not been called familial hypercholesterolemia but have those same patterns. And this work was funded by Stanford, by the AHA, and by Amgen. And what we were able to show is that we can identify undiagnosed FH patients both locally and in very large national aggregated data sets. And I'm going to show you one example which is very impressive from the Family Heart Foundation. And this is a very large data set that the Family Heart Foundation has accrued, which includes data on over 324 million individuals. And we have been able to marry that to lab testing results on hundreds of millions of people. And we're able to take patients that had been identified, unidentified patients, of course, that had been identified not unidentified patients. They were identified, but they were anonymous. We were able to feed what those patients looked like through this computer algorithm and identify patients throughout the country that were likely to have familial hypercholesterolemia. And then through a process, we were able to potentially give that information back to treating clinicians and ask them, if we could go to those clinicians and say, we think that you might have some patients with familial hypercholesterolemia in your panel. Do you want to know who they are? And if they did want to know who they are, then they could be unmasked by the lab testing company. And so this kind of precision screening is now a reality. It's not just a reality for FH, but it's a reality for other potential phenotypes, and this kind of approach is being taken. And it turns out that creating these algorithms is not the hard part. Creating the algorithms is relatively easy, which is shocking. What's hard is to get healthcare systems to integrate this information and to act on it. So, and that's what we're working on. That's what we're focused on right now. So I promised John that I would be done on time. This is a slide from my lab from a few years ago during the pandemic where we went on a hike nearby, which I think probably John used to go running through these hills, but happy to stop and take some questions.
Thanks, Josh. That was wonderful. That slide behind you, that looks like the hills right behind Stanford University. Is that correct?
It's close. These are near Los Altos and Portola Valley, but it's very, very close, very analogous.
Yeah, nice. Wonderful talk, and I particularly liked, you're sitting right at this intersection of basic research, clinical research in genomics, and clinical care in patients with hyperlipidemia and insulin resistance. And you've shown us very compellingly how that kind of, that ability to incorporate all of that knowledge can lead to great clinical care. The question I have for you about familial hypercholesterolemia is tell us a little bit about how you're treating these patients in your clinic right now, and we're just in particularly interested about the newer interference RNA technologies and the...
Yes, this is a great question. And one of the things that has really become, it's been so heartening over the last decade is that we are in a golden age of discovery of new and impressive lipid-lowering drugs. When I started with the Family Heart Foundation, that's just about 10 or 12 years ago. What we had was statins and ezetimibe, and even the data for ezetimibe was not yet as compelling. And since then, we've had an explosion of new data, both for homozygous FH. There are now specific lamidopide and evinacumab. These are extremely severely affected individuals, often with LDLs of over 500. There are now very impressive and compelling medications for those patients. But even for heterozygous FH patients, we now have PCSK9 inhibitors, both antibodies and inhibitory RNAs. And now we're entering an era where we'll be able to do even gene-based therapy, CRISPR-based gene editing, to try to treat these individuals in certain cases. So the genetic revolution and the CRISPR technology and siRNA technology has been extremely important for this patient population. We've now gone from a time when we could only control the lipids of about maybe 20 or 30 or 40% of individuals to now, if we are able to identify them and get them started on a multi-drug regimen, we're able to control the lipids in the vast majority of FH patients.
Yeah. Do you think that inclisiran and some of these other medications are being underutilized in patients with familial hypercholesterolemia?
Yeah, certainly they are. I mean, we have compelling data. We published a lot of this data that a very tiny fraction of familial hypercholesterolemia patients, even familial hypercholesterolemia patients with prior ASCVD, even in those patient populations, multi-drug regimens, including PCSK9 inhibitors and including inclisiran, are vastly underutilized. Mm-hmm. The reasons for that are multifold. Some of it is related to knowledge of the physician. Some of it is related to patient preference. Some of it is related to cost. But a lot of it is the fact that people don't seem to appreciate how much of a risk factor familial hypercholesterolemia is. We published data with the Family Heart Foundation that suggests that if you have FH and you have a prior ASCVD event, you're still at extremely high risk versus other people of recurrent events, and those people are still being undertreated. And these therapies are not only going to be really important for FH, but for the analogous condition lipoprotein A, which now is going to be extremely important. It's a major cardiovascular causal risk factor for both aortic stenosis and coronary disease, and it also synergizes with LDL cholesterol, so that familial hypercholesterolemia patients with high lipoprotein A are at extremely high risk, and so we're very much looking forward to the LPA lowering therapies that should be coming out in the next year or two.
Right, you must be very excited about the new technologies for, well, I suppose you call them gene modulating therapies. You have antisense oligos, you have interference RNA technologies, and base editing technologies. And some of these drugs you can give twice a year. And
Yeah, no, it's incredible. It's incredible that the amount of LDL reduction that we can get, the plaque regression that you can see with very low LDL levels. And I think the gene editing technology is here. I mean, we're already, I'm sure you guys are doing, and we are doing trials now. We're treating patients not just with, not for familial hypercholesterolemia, those are not yet in the US, but amyloid, certain forms of arrhythmogenic cardiomyopathy, other things are now starting to have first-in-man clinical trials of these gene editing technologies, even being able to deliver things to the heart, which is amazing. I mean, familial hypercholesterolemia, we can deliver packages to the liver pretty effectively, but delivering things to the heart is kind of the next frontier.
Mm-hmm. I have one more question to pursue this line, and then I'm going to turn to my junior colleague. But with respect to base editing or gene editing, let me ask you this question. When we have new drugs like the interference RNA and ASOs that you can give twice a year and get an effective reduction in cholesterol, do we really need the one and done base editing, gene editing strategies?
No, I think that's a very compelling question. And I think that the way that I like to approach this for familial hypercholesterolemia patients or for other patients with inherited forms of heart disease is that every situation is going to be slightly different. And sometimes we're going to need to restore gene function, not knock out gene function. And in those cases, gene editing technologies are quite compelling. Sometimes, that one of the ideas is that if you fix something one time, you never have to fix it again. So some of the companies are saying this is ultimately going to be cheaper to do it a one and done approach. But I think you're right that it's not going to be right for everybody. And in certain orphan diseases, I think that gene editing is going to be extremely important because you're not going to, maybe very, very large pharmaceutical companies are not going to want to do these other trials. But I think you're right that it's going to be case by case scenario of what's going to be the winner.
Mm-hmm. Thanks, Josh. Dr. Lai.
Yes. So Dr. Knowles, thank you for the very informative talk. And I know a lot of genetic influence of the disease progression. So my question is, how do you delineate the role of environment to the the genetic variance towards the genetic variance role in disease? So, because you all talk about more like genetics, but how about epigenetics or other environmental effects?
Yeah, epigenetics is a challenge, and it's not something I'm an expert on, but I think the environmental aspects of what you're talking about are extremely important. And one of the reasons that I got interested in genetics and have been interested in genetics, and I think in a cynical way, one of the reasons that many people are interested in genetics is that we can measure things in genetics. We can look at the DNA, we can look at the RNA. It has been extremely difficult to measure environmental exposure longitudinally very well. And that makes it hard to study. And nowadays we have wearables, we have omics, we have things like Mike Snyder is doing where you're doing multiple longitudinal measures of exposures. But it's been very difficult to measure the environmental exposure. Now, when we do these very, very large genome-wide association studies, we're studying hundreds of thousands of individuals. And we know that environmental exposures are going to be high or they're going to be low. And we're looking for consistent signals with the genetics in very, very large populations. And so we know that there's environmental influences, and we just kind of discount them to some extent, in that we say we're going to find the genetics that come through that you're able to see. However, the other point that I would like to make is that the kind of genetic signals that I'm looking for, or that many of us are looking for, they're not deterministic. they increase your susceptibility, but they're not a guarantee you're going to get disease. So when we're talking to patients, I think that's also important to say to them, your genetics is not your destiny. Your genetics is part of the issue, but you can greatly ameliorate your risk of cardiovascular disease or fatty liver or diabetes through environmental exposure, through what your exercise, your diet, your lifestyle, all that things. So I'm sorry that's a bit of a hand-wavy answer, and I don't have a great answer for it, but I think that's where we are right now.
That was a great response, Josh. One thing that struck me in your presentation was that you said 95% of the genetic determinants of insulin resistance are not in the axonic region. In other words, they're not affecting protein coding genes. So it's that the non-coding genes that are involved. What's going on there? Is it non-coding RNA?
So maybe I misspoke, but they are controlling. We think that they're not controlling the amino acids of the protein itself, but they're controlling the gene regulation of those proteins. So it's not non-coding genes; it's coding genes. But they're mostly of the variants that we've identified are probably regulatory variants rather than protein coding variants, if that makes sense.
Sure, it does. And how much of that is non-coding RNA, regulatory RNAs?
Oh yeah, that's been very hard to tease out, but a substantial portion. And link RNAs, all those things. That's a very, very hot topic right now. It's been very difficult to tease out, but I think that that can largely explain some of the gaps in knowledge that we've had.
The other thing you showed us is that you were co-localizing these genetic variants with other risk factors, and you use that to kind of tease out those factors that are causal and those factors that are associated. Because of the genetic co-localization. And one of the factors that you said was not causal was CRP. And maybe talk a little bit about that, because I think that might be somewhat controversial, since we have some clinical studies suggesting that treating to a low CRP does seem to have benefit.
Yeah, no, I think that's an important thing to tease out. So, CRP is one of the canonical markers. That's the kind of a poster child for this. I mean, CRP is clearly associated with coronary heart disease. Increased CRP levels associate very strongly with CRP levels. But treating LDL cholesterol or other risk factors does decrease CRP. So the major question that pharmaceutical companies have and that other companies have is, if we were to design a drug specifically to lower CRP, like if we were to knock out CRP, would that decrease the risk for coronary heart disease? And the genetic data and even some of the other data, orthogonal data, mouse data, other data, strongly suggest that CRP is not in the causal pathway for atherosclerosis. It's a readout of inflammation, but we need to treat the inflammation and then the lipids, and then that readout will go down. So that's really a great example. HDL is another example of the way that these genetic approaches can help us, target our long-term studies and our therapies in that direction.
Thank you. I think Dr. Lai has a question.
So, because Dr. Knowles, you mentioned that the emergent role of the gene editing therapy. So I want to know what's your opinion about that in terms of do we need to, do we have anything that we need to consider, and if there's any drawback from being applied this therapy?
Absolutely. So gene editing, the idea of gene therapy has been around for a long time. And it has actually been hard to deliver gene therapy to the right tissues for many diseases. But we do have poster children where gene therapy seems to have worked very well for very debilitating conditions where there's not great treatments, where morbidity and mortality is high, where you don't have good drugs, where you need to start very early in life, things like this. So for debilitating conditions for where there's no treatment, I think it's really important for the scientific community to think about how we're going to address this. I'm not talking about doing gene therapy to, alter, athletic performance or, things like this, or hair color, stuff like that. But for debilitating conditions, I think gene therapy and gene editing hold a lot of promise. And but there are considerations. Some of the considerations are how do you deliver the payload? How do you deliver the gene or the base editing technology? And delivering them oftentimes until recently has been through viruses, and that has its own issues. Other delivery vehicles can have some toxicity. One of the gene therapy companies had to stop one of their trials because the lipid nanoparticle that they were using seemed to cause some liver inflammation. So that's one potential side effect. The other is, are there off-target effects? Are you editing what you say you think you're editing, or is it editing something else that you don't want to edit? And I think the technology now and the data that's emerging is that these therapies can be very, very specific, way more specific than other drugs that we commonly give, like chemotherapy agents that affect many areas of the genome. These are way more targeted. Another thing to think about is, are you editing the germline? And I think there are approaches to assess that risk, and that risk is quite low. So I think that there are conditions: amyloid, sickle cell, cystic fibrosis, muscular dystrophy, maybe some severe cases of familial hypercholesterolemia, inborn errors of metabolism, where gene editing, gene therapy will be quite efficacious.
I wonder if you might comment a little bit on environmental and gene interaction. And if you just an example of a novel environmental interaction, microplastics seem to be incorporating into our body and into plaque. And wonder, what you think about that particular environmental factor and its interaction with the genetics, or any other that you're interested in, any novel environmental factors.
This is, I think, I don't know as much about that, but I think that another microplastics is another form of pollution. And I think we are increasingly learning that pollution does have an impact on coronary disease risk in particular, and probably also diabetes risk. And those mechanisms have been not well understood and are really emerging. But I think we have not yet. What you really need to do to study gene and environmental interactions is you have to have extremely large data sets with very good exposure data, environmental exposure data. And we are finally to the point with things like the Million Veteran Program or UK Biobank or All of Us, these very large studies, that we might be able to start to tease out those environmental and gene interactions. And I think that they are going to be quite important. But I don't think we have like a lot of ironclad examples of those yet.
Well, Josh, this was fascinating. It was great to see you again. You're doing spectacular work, spectacular research, education, clinical care, and the combination of that has been impressive. And you're doing great work for the country and for humanity. And appreciate you being on the show today. Thanks for joining us.
Thank you so much for having me. This is a great forum, and please reach out for any other questions. I'm always happy to chat. But thanks again. Great to see you again, John.
That's great. You've been at the cutting edge of cardiovascular sciences. Our guest today was Dr. Josh Knowles from Stanford University, who was telling us about genetics and hyperlipidemia and insulin resistance. And thank you for joining us today.